I think over the last 5 to 10 years, there's been more and more attention paid to how we control blood sugars in patients who are hospitalized. It seemed like in the past we thought, it didn't matter what the blood sugars were running. So we'd let them come in and we would treat them for their pneumonia or their emphysema exacerbation, and we would just write a standard sliding scale, which we used for every patient. Didn't matter what their baseline control was like, we'd write the same sliding scale. And unfortunately, what we found, and I think what anyone who's done this knows, is that that doesn't really control the blood sugars very well. And what's happened is that we're finding more and more evidence that this is likely harmful to patients. And so we know from experimental models that hyperglycemia can actually cause problems with the immune function, increased poor wound healing, can cause endothelial dysfunction, procoagulable states. And lately we've had more and more data from clinical trials showing that there's a strong correlation between patients with hyperglycemia and bad outcomes. So in many patient populations, for example, post-heart surgery patients, we know that hyperglycemia causes an increased risk of deep sternal wound infections, as well as mortality, actually. Stroke patients have poor functional outcome if they're hyperglycemic, as well as a worse spinal infarct size. So what we didn't have was trials showing whether that was simply the result of illness severity or whether hyperglycemia actually was causing those bad outcomes. So we needed some intervention studies, and we have some of those now. We certainly need more. The intervention studies that have been done really have been done largely in intensive care patients and post-cardiac surgery patients. The overwhelming weight of those studies is in favor of intensive glycemic control, showing that when we do control blood sugars tightly, we reduce both morbidity and mortality in those populations of patients.